Antitussives, codeine and dextromethorphan. Antitussives are drugs that suppress the cough reflex and are primarily used in dry, non-productive cough, where there is no useful sputum to be expelled. Codeine. Mechanism of action. It is an opioid agonist at mu receptor. It acts on the cough center in the medulla. It raises the threshold for cough, reducing frequency and intensity. It also produces mild analgesia and sedation. Adverse effects: sedation and drowsiness, respiratory depression at high doses, constipation, dependence and abuse potential. Clinical uses: dry, irritating cough, nocturnal cough causing sleep disturbance. Dextromethorphan. Mechanism of action: it is a non-opioid antitussive that is structurally related to opioids, acts on the medullary cough center, suppresses cough reflex without significant analgesia or respiratory depression, may act via NMDA receptor antagonism. Adverse effects: mild drowsiness, dizziness, nausea. High doses may produce euphoria, hallucinations, and there is abuse potential. Clinical uses: dry cough, preferred over codeine due to better safety profile. Common ingredient in over-the-counter cough syrups. Key differences: dextromethorphan is the preferred first-line antitussive due to its safer profile, with minimal respiratory depression and low dependence risk. Codeine is an opioid that causes sedation and dependence. It is reserved for cases where its additional analgesic and sedative effects may be beneficial. Guaifenesin, expectorant. Guaifenesin is the most widely used expectorant or mucokinetic agent, found in many over-the-counter cough and cold preparations. Mechanism of action: Guaifenesin is an expectorant that facilitates the removal of bronchial secretions. It increases respiratory secretions, causes vagal stimulation, reduces viscosity of mucus, and enhances ciliary clearance. Overall, it converts thick, tenacious sputum into looser secretions that are easier to cough out. How it works in the airways: it acts by increasing the volume of respiratory tract secretions. It produces reflex stimulation of bronchial gland secretion via vagal pathways, likely initiated by mild irritation of the gastric mucosa. It reduces viscosity and increases hydration of mucus, making it less sticky and easier to expel. Enhances ciliary activity, improving the natural mucociliary clearance mechanism of the airways. Adverse effects: nausea and vomiting due to mild gastric irritation are the most common side effects. Drowsiness and dizziness may occur occasionally. Allergic reactions are uncommon but possible. Clinical uses: it is used for productive cough with thick and difficult to clear mucus, in chronic obstructive conditions like COPD and bronchitis. It helps manage excessive mucus production and improves airway clearance in bronchiectasis. It is effective when sputum production is a prominent feature of respiratory tract infections. Guaifenesin at a glance: it is a reliable, well-established expectorant used across multiple respiratory conditions to ease mucus clearance and improve patient comfort. N-Acetylcysteine, mucolytic agent. N-Acetylcysteine, or NEC, is the classic mucolytic agent. Unlike expectorants that just add volume to mucus, NEC chemically alters the mucus structure to break it down at the molecular level. Mechanism of action: mucolytic action. It breaks disulfide bonds in mucoproteins. It depolymerizes mucus, reducing its viscosity and elasticity. It facilitates ciliary clearance and expectoration. Overall, it liquefies thick, tenacious mucus. Additional action: it acts as a precursor of glutathione, providing a significant antioxidant effect in the respiratory tract. Adverse effects: respiratory. It may cause bronchospasm, especially in asthmatics. Gastrointestinal. Nausea or vomiting may be encountered. Hypersensitivity. Rash or urticaria may be seen. Others: It has an unpleasant sulfur-like odor. Clinical uses. It is useful in patients with productive cough with thick mucus, as in chronic bronchitis, COPD, cystic fibrosis, etc. It is also effective in acute respiratory conditions like pneumonia. NEC as antidote. One of NEC's most critical clinical roles is as the antidote in paracetamol poisoning, replenishing glutathione stores to protect the liver from toxic metabolites. Key takeaway. NEC is more effective than expectorants in very thick mucus, as it chemically dismantles the mucus matrix, rather than simply increasing its volume. Beta-2 agonists. They are the most commonly used bronchodilators for obstructive airway diseases. They are classified into short-acting beta-2 agonists, like salbutamol, and long-acting beta-2 agonists, like salmeterol or formoterol. Mechanism of action. Beta-2 agonists stimulate beta-2 adrenergic receptors in bronchial smooth muscle. Binding activates the enzyme adenyl cyclase, which converts adenosine triphosphate into cyclic adenosine monophosphate. This leads to the relaxation of bronchial smooth muscle, causing bronchodilation. Beta-2 agonists also inhibit inflammatory mediator release from mast cells and improve mucociliary clearance, providing rapid effective relief of bronchospasm. Adverse effects. Fine tremor is the most common side effect. Tachycardia and palpitations are commonly seen. Nervousness and restlessness may occur. Hypokalemia is seen at high doses due to intracellular shift of potassium. Clinical uses. Key distinction. Short-acting beta-2 agonists are used as rescue therapy for acute bronchospasm. Long-acting beta-2 agonists are used as maintenance therapy, always combined with inhaled corticosteroids in asthma. In hyperkalemia, beta-2 agonists shift potassium intracellularly, lowering serum potassium levels. In bronchial asthma, short-acting beta-2 agonists provide acute relief. Salbutamol is used as rescue therapy during acute bronchospasm episodes, while long-acting beta-2 agonists are used for maintenance therapy. Salmeterol or formoterol are used for long-term control, always with inhaled corticosteroids in asthma. In exercise-induced asthma, they are used for prevention of symptoms before exercise. In COPD, they are used for relief of symptomatic bronchoconstriction. Both short-acting and long-acting beta-2 agonists have roles in COPD management. Key takeaways. They bind beta-2 receptors, activate adenyl cyclase, which converts ATP into cyclic adenosine monophosphate, and produce bronchodilation. Common adverse effects include fine tremor, tachycardia, nervousness, and hypokalemia at high doses. Short-acting beta-2 agonists are used for rescue therapy, and long-acting beta-2 agonists are used for maintenance therapy, always with inhaled corticosteroids in asthma. They are also useful in COPD, exercise-induced asthma, and hyperkalemia management. Inhaled corticosteroids. They are the most effective long-term controller medications for asthma management, reducing airway inflammation, preventing exacerbations, and improving quality of life. Mechanism of action. Inhaled corticosteroids bind to intracellular glucocorticoid receptors, modifying gene transcription to produce powerful anti-inflammatory effects. They decrease cytokines, prostaglandins, and leukotrienes, inhibit phospholipase A2. They reduce eosinophils, mast cells, and T lymphocytes in the airways. They reduce airway edema and mucus secretion, decrease airway hyperresponsiveness. They increase beta-2 receptor sensitivity, enhancing bronchodilator effect. Adverse effects. Local and common effects include oropharyngeal candidiasis or oral thrush, dysphonia or hoarseness, throat irritation. Systemic effects seen with high dose or prolonged use include adrenal suppression, which is rarely seen, osteoporosis, skin thinning, easy bruising. Reducing side effects. Using spacer and rinsing mouth after inhalation can significantly reduce both local side effects and systemic absorption. These simple measures are especially important for patients on moderate to high doses of inhaled corticosteroids. Clinical uses. Inhaled corticosteroids are the first-line therapy for patients of all ages with persistent asthma. Their daily use helps to control symptoms like wheezing, coughing, improve lung function, and prevent long-term airway remodeling. Their regular use significantly reduces the frequency and severity of asthma attacks and hospitalizations. They are preferred treatment for managing nighttime awakenings due to asthma. Step-up therapy. In moderate to severe cases, inhaled corticosteroids are often combined with long-acting beta-2 agonists for enhanced control. A classic example is the budesonide formoterol combination inhaler, providing both anti-inflammatory and bronchodilator action in a single device. Summary at a glance. Glucocorticoid receptor binding leads to reduced inflammation, edema, and hyperresponsiveness. Local side effects include oral thrush, dysphonia, throat irritation, which can be minimized with spacer and mouth rinse. Systemic side effects include adrenal suppression, osteoporosis, skin thinning. Risk increases with high or prolonged doses. Clinical role. They are used as first-line therapy for persistent asthma, combined with long-acting beta-2 agonists in step-up therapy. Anticholinergics in asthma. Anticholinergics such as ipratropium block M3 receptors in the airways, producing bronchodilation and decreased mucus secretion. They serve as key adjunct therapy in both acute and chronic asthma management. Mechanism of action. Anticholinergics competitively block acetylcholine from binding to muscarinic receptors in the airways. Bronchodilation. They primarily target M3 receptors on airway smooth muscle cells. Blocking these receptors inhibits parasympathetic nerve-mediated muscle contraction, leading to airway relaxation. Reduced secretions. These drugs also block M3 receptors on submucosal glands, which decreases the production and release of mucus in the lungs. Inhibit reflex bronchoconstriction. They prevent vagal reflex arcs triggered by irritants like allergens or smoke that otherwise cause acute bronchospasm. Why M3 receptors? M3 receptors are the dominant muscarinic subtype on both airway smooth muscle and submucosal glands. Selective blockade at these sites produces targeted bronchodilation with minimal systemic effects, making inhaled anticholinergics a precise therapeutic tool. Adverse effects. Modern inhaled anticholinergics are quaternary ammonium compounds with poor systemic absorption, making them generally safe and associated with fewer side effects than older agents like atropine. Common adverse effects include dry mouth, most common, throat irritation, cough. Less common adverse effects include blurred vision if aerosol reaches eyes, and rarely urinary retention or constipation. Clinical uses. Acute severe asthma. Short-acting muscarinic antagonists like ipratropium bromide are used as adjunctive therapy alongside beta-2 agonists like salbutamol in emergency settings. The combination delivers greater bronchodilation than either agent alone. Chronic asthma, long-acting muscarinic antagonists like tiotropium are used as add-on therapy when patients are inadequately controlled on beta-2 agonists and inhaled corticosteroids. Special situations. Anticholinergics are sometimes better tolerated than beta-2 agonists in elderly patients, making them a preferred option in this population. Summary. Anticholinergics provide targeted M3 receptor blockade, leading to bronchodilation, reduced airway secretions, and inhibition of reflex bronchoconstriction. They have a favorable safety profile, but their role in asthma is mainly as adjunct therapy, not first line, whereas they are more central in COPD management. Leukotriene antagonists. Leukotriene receptor antagonists such as montelukast and zafirlukast are oral medications used as add-on therapy in asthma. Mechanism of action. Leukotriene receptor antagonists block cis LT1 receptors in the airways, thereby preventing the action of leukotrienes LTC4, LTD4, and LTE4. This leads to reduced bronchoconstriction, reduced airway inflammation, reduced mucus secretion, and reduced airway edema. Net effect: improved airway patency and reduced asthma symptoms. Adverse effects. These drugs are generally well tolerated. Common side effects include headache and dyspepsia. Rarely, they may cause neuropsychiatric effects, such as agitation and sleep disturbances. Clinical uses. Chronic asthma prophylaxis. They are used as add-on therapy in mild to moderate persistent asthma. They are not used for acute attacks. Aspirin-induced asthma. They are particularly effective as leukotrienes play a major role. Exercise-induced bronchospasm. They help prevent symptoms triggered by physical activity. Allergic rhinitis. They can be used as an alternative to antihistamines. Key takeaways. Leukotriene receptor antagonists are used as add-on therapy in asthma. They are not effective as monotherapy and are not used for acute attacks. They are administered orally, which offers a clear convenience advantage compared to inhaled medications, especially for long-term use. These drugs have multiple clinical uses, including asthma, exercise-induced bronchospasm, and allergic rhinitis. Methylxanthines. Methylxanthines, such as theophylline and aminophylline, were once widely used in asthma but are now reserved for refractory cases due to their narrow therapeutic index and the availability of safer alternatives. Mechanism of action. Methylxanthines act by inhibiting phosphodiesterase, which leads to an increase in intracellular cyclic adenosine monophosphate, or CAMP levels. This rise in CAMP causes relaxation of bronchial smooth muscle, resulting in bronchodilation. They also antagonize adenosine receptors, thereby preventing adenosine-induced bronchoconstriction. In addition, these drugs improve diaphragmatic contractility, which enhances respiratory efficiency. They also exert a mild anti-inflammatory effect in the airways. Overall, they produce bronchodilation and improve respiratory function. Adverse effects. Common adverse effects include nausea, vomiting, headache, insomnia, palpitations. Serious dose-related effects include cardiac arrhythmias, seizures. Risk rises sharply with toxic serum levels. Clinical uses. Chronic asthma. Methylxanthines are used as add-on therapy in patients with chronic asthma who remain symptomatic despite standard treatment. However, they are not first-line agents due to their narrow therapeutic index and potential for adverse effects. Acute severe asthma. Intravenous aminophylline may be considered in refractory cases of acute severe asthma, particularly when there is an inadequate response to conventional therapy, such as beta-2 agonists and corticosteroids. It is less commonly used now due to safety concerns and availability of better alternatives. Chronic obstructive pulmonary disease, or COPD. Methylxanthines can be used as adjunct bronchodilators in COPD, especially in patients who do not achieve adequate symptom control with inhaled therapies alone. Narrow therapeutic index. Methylxanthines have a narrow therapeutic index, so small changes in dose or metabolism can cause toxicity, requiring serum level monitoring. Drug interactions. Methylxanthines are metabolized by hepatic CYP1A2. Inhibitors such as erythromycin and ciprofloxacin increase theophylline levels, causing toxicity, while inducers such as rifampicin and smoking decrease levels, reducing efficacy. Key takeaways. Methylxanthines act by inhibiting phosphodiesterase, leading to an increase in intracellular CAMP, which results in bronchodilation. They also act as adenosine receptor antagonists, further contributing to airway relaxation and improved respiratory function. They are used in refractory asthma as add-on therapy when standard treatments are inadequate. They may also be used as an adjunct bronchodilator in COPD. However, they are never used as first-line therapy due to safety concerns and availability of better alternatives. Methylxanthines have a narrow therapeutic index. Therefore, drug level monitoring is essential. They are metabolized by CYP1A2, so potential drug interactions must be considered. Mast cell stabilizers. Mast cell stabilizers like cromolyn sodium and nidocromil are non-steroidal controller medications used to prevent asthma symptoms. They are not effective for the relief of acute attacks. Mechanism of action. Mast cell stabilizers inhibit degranulation of mast cells, stabilizing their membranes and blocking release of inflammatory mediators such as histamine, leukotrienes, and prostaglandins. This suppresses both early and late phases of the allergic response, reducing airway inflammation and bronchial hyperresponsiveness. Adverse effects. Generally very safe with minimal systemic absorption, one of the safest classes of asthma medications available. Common adverse effects include throat irritation, cough, bad taste, especially with nidocromil. Rare adverse effects include paradoxical bronchospasm, hypersensitivity reactions, clinical uses, bronchial asthma prophylaxis, used in mild persistent asthma, especially useful in pediatric population, not effective in acute attacks. Exercise-induced asthma, taken 10 to 15 minutes before exercise to prevent bronchospasm. Allergic conditions, allergic rhinitis as nasal spray, allergic conjunctivitis as eye drops, especially useful in pediatrics. Mast cell stabilizers are a preferred preventive option in children with mild persistent asthma due to their excellent safety profile and minimal systemic absorption. Key takeaways: no bronchodilator action, used only for prophylaxis, not effective in acute attacks. Safer alternative to inhaled corticosteroids, though less effective overall. Must be taken 10 to 15 minutes before exercise for exercise-induced asthma prevention. Management of status asthmaticus. Status asthmaticus, or acute severe asthma, is a medical emergency where an attack does not respond to initial standard treatments. Management requires immediate hospitalization and aggressive therapy. Immediate general measures. Oxygen therapy. Target SpO2 of 93 to 95% via high-flow face mask. IV fluids. Correct dehydration and liquefy thick mucus plugs. Continuous monitoring of heart rate, respiratory rate, SpO2, and ABG for CO2 levels. Pharmacological treatment. Inhaled bronchodilators. Salbutamol is given via oxygen-driven nebulizer every 15 to 20 minutes, or continuously in severe cases. Inhaled anticholinergics. Ipratropium bromide is added to the salbutamol nebulizer. This dual blockade is more effective than SABA alone in status asthmaticus. Systemic corticosteroids. IV hydrocortisone 100 mg every 6 hours is started immediately to reduce airway inflammation. This is the most critical step for long-term recovery. Second line or rescue options. Magnesium sulfate. Single dose of 2 grams in 100 milliliters normal saline IV over 20 minutes is often given to patients who do not respond to initial nebulizers. It acts as a potent smooth muscle relaxant. Aminophylline. Sometimes given as an IV infusion if the patient is not responding, though its use is declining due to toxicity risks. Mechanical ventilation. If the patient shows signs of respiratory failure, such as rising CO2 levels, exhaustion, or altered consciousness, they should be transferred to the ICU. BiPAP or non-invasive ventilation may be tried in selected cooperative patients. It is preferred first-line strategy if tolerated. Intubation and mechanical ventilation is required for impending or established respiratory failure. It is used when BiPAP fails or is not suitable. Summary stepwise approach. Step 1. Oxygen, IV fluids, continuous monitoring and ABG. Step 2. Salbutamol plus ipratropium nebulizers, intravenous corticosteroids. Step 3. Intravenous magnesium sulfate 2 grams. Consider aminophylline if refractory. Step 4. ICU transfer for BiPAP or intubation if respiratory failure develops.